This slide demonstrates a typical transitional vertebrae, usually at T11 or T12. Take a few moments, and can you identify some of the characteristic features? The superior articular processes are orientated in the coronal plane, and the inferior articular processes are orientated in the sagittal plane. The articular processes of the upper part of the thoracolumbar junction have a similar morphology to the thoracic spine, while the lower thoracolumbar junction articular processes resemble the lumbar spine. This sagittalization is thought to be due to the change in the direction of weight transmission through the zygapophyseal joints at the thoracolumbar junction. The vertebral bodies, as can be seen here, are short and large and are wedge-shaped anteriorly. The spinous processes are short and stout and do not overlap, making them a reliable bony landmark for palpating intervertebral movements. The transverse processes have been replaced by 3 tubercles, with the mammillary process, number 5, being the larger and more superficial. The multifidus muscle attaches to the mammillary process. There is a single ovoid facet on the side of the vertebral body to form the costovertebral joint. Comparing the thoracolumbar junction to the other regions in the spine, this slide visualizes some of the differences. Note the shape of the vertebral foramen, the size of the vertebral bodies and the transverse processes, and the orientation of the facets. The thoracolumbar transitional zone marks an increase in the size of the vertebral bodies and the disc, associated with a larger vertebral canal to accommodate the lumbar enlargement of the spinal cord and the conus medullaris. According to Singer et al., there is a tendency for the anterior aspect of each vertebral body to demonstrate a significantly higher trabecular density, which may be accounted for by the greater flexion loading sustained by the low thoracic and upper lumbar vertebrae. The consistent finding of anterior osteophytes in this region supports its weight-bearing function. The thoracolumbar junction is a transition zone between the kyphotic thoracic spine, which primarily rotates, to the lordotic lumbar spine, which primarily flexes and extends. It demonstrates specialized anatomy and biomechanics, and it is also a common area for articular tropism. The facet orientation has been found to be 25 to 30 degrees tipped forward from the frontal plane for the T1 to T11 segments, and approximately 30 degrees anterior from the mid-sagittal plane for the T11 to L2 segments. Facet joint orientation has been reported as independent of age, gender, and ethnic group. Facet size, however, has been found to be greater in males than females, and the facet dimensions vary with an individual's height and weight. CT scanning in 630 normals showed that 70% of individuals have a gradual transitional region, most commonly through the T11 to L1 region, while 30% had an abrupt transition, most commonly at T11, T12. Recent studies, however, with smaller sample sizes, express conflicting patterns. 2 reporting that in the majority of specimens there was an abrupt transition, 66 to 94%, and it most commonly occurred at the level of T12L1, followed by T11 T12. And another study reported gradual transitions in 97% of the spines they looked at. Singer et al. In 1989 reported that in a sample size of 600 patients, a gradual or progressive change from T10 to T11 to T12 to L1 appears to be the most common junctional pattern. The more gradual form of transition was largely a female characteristic. This may be related to adaptations to different mechanical demands. Female role as a childbearer requires a broader pelvis, which may produce greater rotation of the thoracic and thoracolumbar region, especially during gait. The drawing on the left shows the orientation of the superior articular surfaces from T9 to L5. The column shows a sudden change at the T12 vertebral level. On the right, the photograph shows the T10 to L1 vertebrae. A sudden change is seen again at T12. The mammillary tubercle is seen on the transverse processes of T10, 11, and 12 on the upper three vertebrae. On L1, the mammillary process is seen on the superior articular process of the L1 vertebrae. Singer et al. Using CT studies demonstrated ipsilateral compression and contralateral separation in the sagittally directed articular surfaces, whereas the coronally directed joints tended to show translatory displacement. Controversy exists as to whether tropism is common at the thoracolumbar junction. Singer et al. Reported that tropism of more than 20 degrees between joint planes was 2 times more frequent in males. The theories proposed to account for the tropism are varied. Performance of manipulative tasks using the dominant upper extremity have been suggested, while others believe that multifidus controlled the development of lumbar Z-joint sagittal orientation, and that this may account for the variety of articular plane orientations. Z-joint tropism occurs most frequently at the T11-T12 segment. In this slide, we can see a horizontal plane CT slice through the superior end plate at the T11, T12 in 2 individuals. The gradual transition pattern is depicted in A, and marked articular tropism between the right and the left articular planes is seen in figure B. Mortise joints are simple, yet they are strong. Another example in the body would be the talocrural joint of the ankle. Mortise joints are unique to the thoracolumbar junction, and it has been reported that there is a 30% incidence. T11, T12, and T12L1 are the most common vertebral segments. Often we see it asymmetrically or unilaterally, and it decreases the mobility of the segment. These interlocking facet joints allow very minimal gliding motion to occur. This slide shows a transverse section cut in the plane of the superior vertebral end plate at T11, T12. You can see a mortise joint on the left formed by the mammillary process located posteriorly to the inferior articular process. The Z joint on the right conforms to a typical sagittally orientated joint. This specimen demonstrates marked articular tropism. So what is the clinical relevance of this information? Let's take a few moments to consider this. The thoracolumbar junction is an important site due to movement pattern transitions. Since every individual transitions slightly differently, it's important to assess the PIVMs in this area for each person and to mobilize according to the joint planes found on assessment at each joint level. Individuals who have an abrupt transition may have a mortise joint, which allows no side flexion or rotation in full extension. If this is present, it is important to avoid mobilizations and manipulations in extension for these joints. As in the other regions in the spine, interarticular synovial folds have been demonstrated consistently in the thoracolumbar region. They act as displaceable space fillers, which deform to accommodate for the incongruities between the articular surfaces that occur during normal joint movements. Fibroadipose folds are noted more in the coronally orientated joints and may be better suited for the marked translatory movements. In contrast, fibrous folds predominate in the more sagittally orientated joints, occasionally showing histological evidence of fibrosis at their tips, to suggest that these folds may become tractioned or compressed. In the normal posture, the location of the line of gravity in relation to the vertebral column appears to be consistently located through the transitional zones. This reciprocal change in the curvature of the thoracic kyphosis and lumbar lordosis produces an inflection point which is commonly located between T11 and L1. This provides protection in the form of reduced localized bending stress for sagittal plane motion. If the bending moment is applied suddenly, the thoracic column tends to pivot over the mechanically stiffened thoracolumbar junction, which could result in fracture. During static axial loading, the thoracolumbar junction shows little rotational deformity in the horizontal plane compared to the thoracic and lumbar regions. This mechanical characteristic could be thought of as an anti-torsion device, and it appears to reflect the increased stability of this region during the loaded postures. According to Diane Lee, the coupled movement pattern for rotation in this region can be either ipsilateral or contralateral side flexion. The coronally directed facets of the Z joints do not dictate a specific coupling of side flexion when rotation is induced. The absence of a costotransverse joint and the lack of a direct anterior attachment of the associated ribs facilitates this flexibility in motion patterning at the 11th and 12th segments. Anatomically, the human thoracolumbar junction demonstrates considerable resistance to rotary motion in an effort to decrease the torsional stress through an area of marked functional transition. Clinically, we often find that we use more of a side flexion vector when assessing and treating this area than a rotary vector. It has been advocated in the past that it could be potentially dangerous to apply rotational manipulation and mobilization procedures at the thoracolumbar junction. We must remember, however, that 70% of individuals will have a gradual transition rather than an abrupt transition. So therefore, it is important to assess our PIVMs and our PAVMs to determine the coupling pattern for each individual patient. The thoracolumbar junction is a region of transition from thoracic rotation to lumbar flexion. We can identify the thoracolumbar junction by noting where there is a marked decrease in flexion as we test the flexion PIVM from the lumbar to the thoracic region, or we can identify it by noting the marked decrease in rotation as we test the rotation PIVM from the thoracic to the lumbar region. An early sign of the stabilizing role of the thoracolumbar junction appears in the sequence of ossification. A number of reports have indicated that the first sites of ossification are consistently located in the lower two thoracic and first lumbar vertebral bodies. The thoracolumbar fascia is an important structure when we consider how loads are transferred between the trunk and the lower extremities. The posterior layer of the fascia is a strong sheet of connective tissue linking two of the largest muscles of the body, latissimus dorsi and gluteus maximus. According to Vleeming et al., it connects these muscles functionally in a way that promotes the coordinated activities of the upper and lower limb, notably the pendulum-like actions of the contralateral arms and legs during walking and running. Transversus abdominis and the internal oblique muscles are attached via the middle layer of the thoracolumbar fascia to the tips of the vertebral transverse processes, and they are important in lumbar segmental control. Here we can see how the pull of a contraction of the transversus abdominis and internal oblique can help to increase the compressive strength of the lumbar vertebral bodies. Quadratus lumborum is an important muscle to consider in the thoracolumbar region. It attaches to the transverse processes in the lumbar spine, to the 12th rib, and to the iliac crest. In a very recent study, Park et al. Found that the anterior and posterior fibers of quadratus lumborum showed similar activation during trunk loading in different directions. The only exception was that they found greater EMG activity of the posterior fibers during ipsilateral trunk lateral flexion. This finding is consistent with previous EMG studies that show increased QL EMG activity when carrying a load on the opposite side and during contralateral flexion of the trunk. Both the anterior and posterior fibers of quadratus lumborum enhance stability of the thoracolumbar spine in the frontal plane. McGill et al. Reported quadratus lumborum activity during trunk extension efforts. In contrast, the data from this study showed limited activity in pure extension, but they found greater activation when extension was combined with lateral flexion. In this region, it is important to consider the blood supply to the lower part of the spinal cord. The most important anterior radiculomedullary artery, and the one most easily recognized in angiography studies, is the artery radicularis magnus, also known as the artery of Adamkowitz. It has a diameter of 0.5 to 1 millimeters and almost always arises in the thoracolumbar region, between T8 and L2 in 75% of cases. It has, however, been identified as superiorly as T5 and as inferiorly as L4. In 80% of cases, it is found on the left side. The artery of Adamkowitz forms the classic hairpin loop when it reaches the anterior spinal artery, and it gives off a thin ascending branch and a larger descending branch. Portions of the thoracic and upper lumbar spinal cord are extremely vulnerable to ischemic compromise, as there is minimal collateral supply to the spinal cord inferior to the junction of the artery of Adamkowitz and the anterior spinal artery. Additional feeders to the anterior spinal artery below the level of the artery of Adamkowitz are rarely found, and the anterior spinal artery maintains a large caliber until the end of the conus medullaris. This slide shows the skin territories innervated by the T12 and L1. One branch sets off anteriorly to supply the groin or pubic region. A second branch remains posterior, innervating the lower back and gluteal region. And third, there is a lateral branch which passes down the anterolateral thigh or trochanteric region. In our assessment of the thoracolumbar junction, we must be certain to clear for any red flags. This would include any cord and or cauda equina signs and or symptoms. We also must be aware, as noted on the previous slide, of the referral patterns from the thoracolumbar junction, as is noted here. The spinal cord terminates around the level of the first lumbar vertebrae. Patients may present with upper or lower motor neuron signs with canal compression or narrowing at this level. Cauda equina signs and symptoms must also be considered. Takahashi et al. Conducted a retrospective clinical review of patients with thoracolumbar junction disc herniations. The clinical features of 26 patients who had undergone surgery for single disc herniations at T10-11 through to L2-3 were investigated. The key points from the study were as follows. At T10-11 and T11-12, disc herniations were considered upper motor neuron disorders of the spinal cord. T12L1 disc herniations were considered lower motor neuron disorders of the spinal cord. L1-2 disc herniations were considered combined disorders of cauda equina and radiculopathy, and L2-3 disc herniation was considered radiculopathy. The chart in the slide shows that the neurological findings and symptoms of the thoracolumbar junction disc herniations had relatively distinct differences among the herniated disc levels. The following two slides summarize the findings of a literature review conducted by Fraser et al. On the Cauda-Equina syndrome, its definition and clinical presentation. With regards to the bladder, patients may complain of urinary retention and overflow incontinence. Bowel symptoms may include an inability to control defecation or a sense of rectal fullness. With regards to pain, lower extremity symptoms may actually be absent. When they are present, it has been implicated as an indicator of poor outcome in Cauda-Equina syndrome. Unilateral sciatica has a more favorable prognosis than bilateral. With regards to sensation, 3/4 of patients with Cauda-Equina syndrome present with anesthesia of the perineum and saddle area. This is the most striking feature. Complete perineal anesthesia at presentation is considered indicative of a poor prognosis, with residual sphincter dysfunction, post-surgical decompression. Motor weakness can be either unilateral or bilateral. The literature appears unclear. Classic Cauda-Equina syndrome has been described in the literature as producing no motor deficits in the lower extremities, or bilateral paresis and lower extremity flaccid paralysis have also been documented. So what types of mechanisms lead to injury in this area? The curve change from kyphosis to lordosis and the change in movement patterns alters the forces at the thoracolumbar junction, and this may contribute to an increased risk of injuries. It has also been reported that individuals with an abrupt transition have a greater predisposition to injuries at the thoracolumbar junction. At our clinic in the last 6 months, we have seen 3 individuals with fractures in the thoracolumbar junction. One of them was a young individual who fell 30 feet while snowboarding. The other 2 individuals were involved in fairly severe motor vehicle accidents. The types of injuries that can occur in this region include compression fractures, as we can see here. We can also have end plate fractures with the development of Schmorl's nodes. We must also remember that degenerative changes of both the Z joint and the disc can occur in this region. In this slide, we can see the MRI of a burst fracture at the T12 vertebral segment. When classifying burst fractures, they look at the following 3 factors: the local angle of kyphosis, the amount of canal retropulsion, and the amount of loss of vertebral body height. The thoracolumbar injury classification and severity score was introduced by the Spine Trauma Study Group in 2005, and it was designed to provide a clear, reliable classification system. 3 major injury characteristics were defined: injury morphology, neurologic status, and the integrity of the posterior ligamentous complex. Point values are assigned to each major category based on injury severity. The sum of these points represent the TLICS severity score, which may be used to guide treatment. Severity score of more than 4 suggests the need for surgical treatment because of significant instability, whereas a score less than 4 suggests non-surgical or conservative treatment. A patient with a score of 4 may be treated either surgically or non-surgically. This slide shows the findings of an 18-year-old woman who presented with severe mid-back pain following a rollover motor vehicle collision. Patient assessment revealed a normal neurologic examination with a palpable tender gap in the thoracolumbar region. CT scans demonstrated a T11-12 fracture dislocation with a chance fracture at T12. A magnetic resonance image was suggestive of disruption of the posterior ligamentous structure, as can be seen in C. In this patient, the TLICS scoring was as follows: Injury morphology, 3 points. Neurologic status was intact, so 0 points. The posterior ligamentous complex was disrupted, 3 points. The total TLICS was 6 points, which indicated the need for surgical treatment. This patient was treated with an open reduction and posterior spinal fusion, as can be seen in Figure D. Other injuries that can occur in this region include irritation of the lateral dorsal nerves, thoracic disc herniations. We have to remember that there are free nerve endings in the interarticular folds of the zygapophyseal joints, and these can be compressed with repeated or sustained extension. The next 4 slides are courtesy of Dr. Taylor and demonstrate some of these injuries. Here we can see a lower thoracic end plate fracture. The cartilage plate has been fractured, allowing bleeding from the vertebral spongiosa into the fluid nucleus. The disc itself is otherwise uninjured. This slide demonstrates an axial compression injury with bone bruising in the T12 vertebral segment. Here we can see a fracture dislocation at the T12L1 resulting from a fall. There are fractures of the vertebral body and the lamina with disruption of the intervertebral disc. This slide shows the long-term result of a T12 wedge compression injury. After the acute injury, there is further collapse of the damaged vertebral body with a resultant kyphosis. So, what does the evidence have to say about the treatment of thoracolumbar junction dysfunction with manual therapy? Well, a search on Medline came up with very few hits. Here we can see 2 case reports, level 4 evidence for manual therapy and patients with thoracolumbar dysfunction. Based on what you have seen in this presentation, is there anything that you will do different clinically when you are assessing and treating the thoracolumbar region? What subjective and/or objective tests may help you rule in or rule out the thoracolumbar junction, and why? Some things that you may want to consider. There's less rotation and extension at the thoracolumbar junction. Why is this? What about the orientation of the facets? What types of injuries occur here? What is the referral pattern of pain from this area? What about cord and cauda equina signs and symptoms? What's the blood supply to the spinal cord in this region? Think about the muscle and fascial attachments. The thoracolumbar junction appears to be designed for stability. Should our treatment then focus on stability? The next 2 slides include the references used for this presentation. Thanks for listening, and we look forward to seeing you in the Level 3 lower quadrant.